Good afternoon. My name is Eduardo Sanchez, and as I said earlier this morning, I am on the Standing Committee on Childhood Obesity, and I am with the American Heart Association National Center in Dallas, Texas. I am the moderator for this session that is going to cover both of the afternoon panels. For those of you who are on the webinar, I'm just going to kind of go over the names of those who participated in panels 3 and 4. The moderator for panel 3 was Dr. Pat Crawford, and the two presenters were Dr. Ray Baxter with Kaiser Permanente and Sharon Anthony with WICFIT, California. Panel 4 was moderated by Dr. Bill Dietz, and presentations were done by Dr. Burnett from the University of Chicago and Dr. Buchholz, Upper Cardoza Health Center and Unity Healthcare. A couple of things. We've decided to dedicate today's workshop, this entire workshop, to Tony Yancey, somebody who was a friend of mine, and just a little Tony Yancey story. She and I met at an American Heart Association event. It seems like yesterday, but it was more than a decade ago. And it was one of those kinds of situations where it feels like you're both in the same bubble that no one else is a part of. And you'd have thought that we were the only two non-white people in the room with all the trash talking we did. We were not the only two non-white people in the room, but we did keep trash talking throughout the event. And she and I, along with many others, I say that kiddingly, took very, very seriously the challenge that we're still talking about today, which is how do we achieve health equity? How do we completely eliminate racial, ethnic, all disparities associated with health and health care? And so it's an honor for me to be here and an honor to be a part of this particular workshop. I'm also, I just want to say, I wish, and I'll say this on behalf of all the other physicians in this room, I wish all physicians were like the two who presented, Dr. Buchholz and Dr. Burnett. Y'all are doing some amazing work. You've gone beyond the pitching and moaning and whining and thinking about how do I do and what can I do as a physician who's a part of a team, who's a part of an organization, who's a part of a community, who's serving patients and their families to make a difference in their lives. And we need more docs like the two of you. Let's give them a round of applause. Now, I'm not supposed to be doing any talking, so y'all better line up and get on the microphones or else I'll keep on talking. So please get on the microphones. We are going to have a public comment period, and as people line up, I do want to say, I don't know if it's appropriate or not, but this week I received a document from the American Academy of Family Physicians. They're trying, and I think that's the operative word, and the document is called Diagnosis and Management of Obesity. And while it's a decent first step, I would say this needs to be complemented by the transcript of what just transpired and what's transpired throughout the day, so docs begin to have a better understanding of the broader context for addressing this issue, that it's not just about an individual and individual biomarkers, it's much more than that. And then the Journal of Healthcare for the Poor and Underserved has a supplement that came out this month entirely dedicated to advancing obesity prevention. So, you know, things are moving in the right direction, and we have opportunity, I think, to move the needle. I still don't see anybody. Oh, there you go. Question. Yes. And identify yourself, please.
Yes, I'm Joni Eisenberg with DC Department of Health, and I'm also thankful we're dedicating today to Dr. Tony Yancey, who I also work very closely with and feel like I still do. I hope we can all come together to really make something out of November 1st, where we can be doing instant recess in many settings, workplaces, clinics, et cetera. And so my question is, what can we do, and to some of the panelists, to really organize instant recess more officially in health clinics, in WIC clinics, and in work sites, and maybe even in parks. But it seems like we have the opportunity to do that. That's one question. And then at some point I want to talk to Dr. Burkholz from Unity. The DC Health Department gave the first grant to Unity to start the weekend program, and we are seeing that it's moving. It's being very effective with adults, but not as much as with children participating in weekends. So, and we're also struggling with how do we get Medicaid reimbursement for programs like weekend. But I do want people to focus on the instant recess question.
Take it away.
Yeah, thank you for mentioning it, because I think sometimes we forget the power of one. If we expect it in the meetings that we go to, and we all go to a lot of meetings, and if we begin to ask, I found the meetings I've started mentioning it to, you know, the people who are planning the meetings, but I'm in attendance, it happens. So I think that would really, you know, please Dr. Yancey to know that we're taking it out, you know, kind of at the ground level, that each of us are asking for that kind of thing. It's the same thing as when we see people serving, you know, beverages that we don't want, or snacks, you know, that we, you know, make a comment about it, that we're a health group and we'd like to do this and that. But I think the instant resource is just perfect too. And our own Jim Salas, who led the break, not long ago, we were at a meeting with him, and I said, oh, it'd be so great if we did, and he just pulled out the DVD out of his briefcase, so I think we could also carry it with us. So it's easy to get it off the web, or, you know, to get another copy, you know, too. So. I was
referring more structured. Tony really wanted us to move to doing it every day in a structured way.
Yeah, so the word, okay. Okay, so that's good. So I'm trying to, yeah, we want to get it into more organizations and more people to know about it. And let me have Sharon address it about doing it daily or weekly, or how often do you do it?
Well, what we have in terms of our particular agency is we have about 60 sites scattered all over LA County and parts of Orange County, and a little piece in San Bernardino County. And as I had mentioned before, not all of our centers are exactly the same. Some are very small with very few staff, and then others have more staff. So we can't all do it exactly the same. So what we've done is we provided our staff with some videos, or DVDs, excuse me, wrong terminology, and of instant recess. And what they can do is they are allowed to use it either for just themselves in the centers, or use it with participants, and that way they can choose. The difficulty we have, though, with that sometimes is just keeping staff motivated, because after a while, over time, some things become too routine, so we've needed more resources to keep that going. YouTube doesn't work that well for us to download, and of course we're operating on a shoestring budget. So I would say some of the things that we can do to make it work better are things like having it like on DVD, because we know that's a more reliable technology for some of us out in the centers and things. And then I think in terms of making it a policy, I think there are some implications regarding that, because I think being in the structure of a nonprofit organization and people having concerns about liability, which we all understand, we need champions somehow, like Dr. Yancey had done some of the groundwork for that, but to kind of help us talk to the powers that be about how to make it, how to overcome that particular issue. Because a lot of employers won't want their employees to do instant recess. And that is because of the liability issue. So I don't know how else to say that, but it's been very tentative in terms of what we can do. instant recess, as everybody knows, is low impact. It's not anything that is usually causes injury to people, and we always advise our staff to listen to their own bodies and to do what they can based on that. So that's what
Ray is
it's not here. He left.
Yeah.
lucky Ray. Only because he doesn't have to answer the question. You know, there's two things. Just to say, the issue of liability may be one of those issues that needs to be explored. It may be more myth than reality, and we know people who do that stuff that are supported by the Robert Wood Johnson Foundation. And the other is, it is possible for a human being to make noise with their mouth that's a beat, and for another person to dance around. And so we could do instantaneous instant recess or spontaneous instant recess, always acknowledging and paying tribute to Tony Yancey when the technology is not available. Next question.
Thanks, Eduardo. I wasn't sure I could get a word in edgewise here. This is Leanne Birch. I'm a member of the Standing Committee. For either of the positions, and I guess for Sharon, you too, if you'd like to respond, I think one of the topics that's been of interest to a number of us is the whole issue of engagement, particularly with parents and families, and how do we do that, and who gets engaged, and can we get to the place where we can predict who's going to be the type who gets engaged, who comes for 10 sessions versus one and never comes back? I mean, are you, particularly Dr. Buckles, you had that great graph that showed the distribution where you have, you know, the buildup of people on the left side of that bar graph, and how are they different from those that are kind of dribbled off to the right there, who really only came a couple of times? Can you, at this point, when people walk into the clinic, can you spot the ones who look like good prospects, for example?
That's a great question, Leanne. I wish I could say that I knew at this point, but I probably don't know. So, you know, as a result, we've tried to encourage providers at our health center to, you know, just refer whoever they can, and we'll see who sticks, and get them there. But I think if we're able to build up some of our research capacity a little bit, there may be some features that we could call out, or characteristics that might make, you know, predict someone's likelihood of continuing on.
Joey Skelton at Wake Forest, right, has done some work on this kind of drop rate, and has shown that structuring the clinic to meet patients' needs rather than provider needs makes a huge difference in follow-up appointments, and both in terms of readiness to start a program and continuing a program. And I don't think that those practices are widely used or disseminated.
Right. So asking the kids and the stakeholders, whoever they are, you know, what they like, what they want. We did that with focus groups and so forth in the beginning, but even in an ongoing way, getting some input, reiterating it, and making it responsive to their interests. And then also giving them a role and a responsibility. So the kids in our Reach Out program in particular, we worked with the kids and families, and the kids became agents of change within their families. So they would say, you know, I want to go to the grocery store, I want to, you know, make this shopping list. So, you know, getting their input and valuing their contributions, I think, is really important.
I would certainly encourage you to try to collect more information on this issue. It's so important. Thank you.
Yeah, we will. Thanks.
Hi, Chrissy Economos. I'm on the Standing Committee. Thank you all very much for your presentations. And I have two questions. The first, I think, builds on what you were just saying about the dynamic between parents and children and who goes home and encourages change. In your experience, because I think you said you see both adults and children, and even from your experience, spillover effect. Do you find that comes more when you're working with children and they then catalyze change within the home for the adults, or the opposite? Or what can you say about this based on your experience and what the clinical literature tells us? I know a family program is ideal, but scheduling and based on environments where people spend their time, it's often challenging. And the second question is around the financial model of We Can. You mentioned just briefly reimbursements, but someone who's coming 50 times, I would imagine you can't get reimbursement for that many sessions. So how do you fund the several hours of staffing for sometimes a small number of children, and how does that speak to scalability?
Very good questions. For the first question about, is it engaging the child who then spurs on changes in the parent versus engaging the parent who then leads to changes in the children? My sense is a both and. I think in some families, and this gets to the question of who sticks it out and who continues. I think you've got to have, if you're a child, you've got to have a parent who's committed, because otherwise you're not going to be there. We can't see the patient, the kids, unless they've got an adult with them. And so sometimes that's a parent, sometimes that's an aunt or uncle, a grandparent, but definitely having them engaged. And certainly in the home environment, if they're engaged, if the parent's not engaged, it's kind of like we're banging our heads against a wall trying to help the kids when there's junk all around the house to eat and drink. And to the second question around reimbursement, we do, as an Unity Healthcare as an organization, does set aside a small budget for We Can, which helps us, as far as being able to purchase supplies and so forth. But as far as, the DC Medicaid managed care organizations, of which there are 3, and they're in a little bit of transition right now, as our colleague from the Department of Health alluded to. Thus far, they've been very supportive. They've actually, one of them came to us and asked, hey, can we send patients who are non-Unity patients? And they've been able to reimburse us without too many problems. As far as out of the nearly 50 times that a patient comes, certainly not all of those, but for the most part, she's really exceptional, an outlier. Most people are more in the range of 1 to 10 times, and in most cases, we've been able to see like a level 2 or a level 3 visit be reimbursable.
Having a big tent helps, so even if grandma's not a subject in the study, having grandma come to the session if she wants to is great, because then people can get on board together. And then also creative use of technology is another way to reach out and make it available and user-friendly.
Because I would imagine for most kids who you're treating, at least one parent is already overweight or obese, and probably
Absolutely.
2 parents a lot of the time. So the spillover seems important for sustainability of their maintenance of a desirable weight. So, thank you.
We're going to make a little bit of an agenda adjustment. Those of you who are going to ask questions, just hang tight. One of the persons who's going to had signed up to do a public statement has a need to leave before we even start, and so Sarah Bleich from the Bloomberg School of Public Health is going to make her public comment, and then we'll go back to the Q&A if that's all right.